everyone. Welcome to the 2021 Targeted Therapies Forum, KRAS and Rare Mutation Sessions by GRACE, the Global Resource for Advancing Cancer Education. It's really my pleasure to introduce my colleague, Lyudmila Bazhenova. She's a professor of clinical medicine at UC San Diego Moores Cancer Center, and she'll be speaking first on KRAS driver mutations.
Thank you, Dr. Das. It's my pleasure to be here. Let me share my slides. Here we go. All right. So my task today would be to discuss KRAS mutations and the new treatments that we just had approved for lung cancer patients with KRAS mutation. So on May 28, 2021, Food and Drug Administration approved the drug sotorasib for patients with KRAS G12C mutation and stage 4 non-small cell lung cancer. So this increases our armamentarium for patients with lung cancer to 9 targeted drugs that are currently approved, and lung cancer is the only cancer that has so many targeted therapies available to our patients. So what are KRAS mutations in lung cancer? In lung cancer, KRAS is found in approximately 25 to 30% of patients. As you can see on the left side of the slide, there are several KRAS mutations. And the type of mutation is named based on what location in the DNA mutation has happened and what type of the amino acid has switched. So you can see here on the left side of the pie chart, you can have mutations in the position 12, 13, and 61, and those are the most common positions to be mutated in lung cancer patients. And the most common mutation in lung cancer patients is KRAS G12C, which accounts for about 44% of patients, 44% of KRAS mutations. KRAS mutations are seen in other malignancies. As you can see on this bar graph, pancreatic cancer is the cancer that has the most likelihood of harboring a KRAS mutation. Other cancers as colorectal cancer, biliary tract cancer, skin, some GU cancers and head and neck cancers can also have mutations in KRAS. In lung cancer, type of mutations differ based on your history of smoking. Patients who never smoked can also have mutations in KRAS, but as you can see at the bottom part of the slide where you see portion B, where you see never smokers, majority of the patients who never smoked have a mutation in G12D, which unfortunately at this point we have not yet figured out how to target. And in the patients who are former smokers, you can see that 42% of those patients have mutations in KRAS G12C, which is what we will be discussing today. If you look at the lung cancer patients and compare patients who have KRAS mutation and patients who do not, they do not appear to be different by age, gender, or ethnicity. So the only thing we are seeing special about patients with KRAS mutations, the G12C mutation specifically, is those patients are more likely to have a smoking history, 97% of patients with KRAS G12C mutation compared to 87% of the patients without KRAS G12C mutation. So how does KRAS work? It's a little bit complicated, but I think I can hope to make it easy for you to understand. So if KRAS is not mutated, then it cycles between active state, which we call the GTP bound state, and inactive state, which is called GDP bound state. And usually there is an equilibrium. It's like yin and yang. So the active and inactive state are similar in numbers and activity. When KRAS is broken or mutated, then the balance shifts towards the active state. So the receptor becomes more active and therefore signals the cells to divide and grow. So why are we suddenly talking about KRAS? Is it a new mutation? Why we weren't talking about it before? It is actually not a new mutation. So the RAS genes were first discovered in human cancers back in 1982. But the reason why we haven't talked about it, because were nothing to talk about. As a clinicians, as researchers, we have tried, unfortunately unsuccessfully, to target KRAS using treatments or using strategies that worked in other mutations. We've tried blocking active KRAS by attaching something to the active part of the KRAS, and we couldn't do that. We tried blocking downstream signaling, but the KRAS was quickly able to find kind of a go around to the bypass pathway, and we couldn't do that too. And then we tried blocking attachment of the KRAS to the cell membrane, which is necessary for the KRAS to signal, and it just didn't happen as well. So until recently, we thought that KRAS mutation is actually what we called an undruggable mutation, meaning we can't interrupt the signal through the mutated KRAS. But now we're actually able to crack the KRAS code, cracking the code was very unusual. This is the first time we actually were able to successfully target KRAS by thinking a little bit outside of the box, so not using strategies that work for other mutations. So how do we figure it out? So what happens is when you have a KRAS mutation G12C, in the area of DNA close to the C, there is a new tiny pocket. And we figured out how to fit the drug in that tiny pocket. And once the drug fits in that tiny pocket, it kind of locks the mutation in an inactive state. So it cannot go into the active state, therefore restoring the balance between active and inactive KRAS, and therefore interrupting the signaling, the increased signaling to the cancer cell to divide and grow. So lung cancer, we are, if you can call us lucky, but we are lucky because patients with lung cancer have the highest incidence of a KRAS G12C mutation. As you can see on this slide, KRAS G12C is in a light orange color, and you can see on the pie charts that lung cancer have the highest incidence of KRAS G12C. Other cancers that have KRAS G12C are colorectal, pancreatic, and biliary tract. And in lung cancer, about 13% of lung cancer have a KRAS G12C mutation, and about 3% of colon and appendix cancer, and you have about 1 to 3% of patients with other solid tumors that also have a KRAS mutation. So we now have two drugs. One is FDA approved, which is sotorasib, and one is still being investigated, adagrasib. And when we evaluate targeted therapy for cancer patients, we want to know, number one, what is the chance of a cancer responding to the treatment if I give the drug? We also want to know how durable is the response, because I wouldn't be interested in a drug that works for a week. I want to see the drug that works for several months before I have to switch therapy. And what I showed you here, for those of you, I know a lot of you are probably familiar with what we call the waterfall plots, but then for those of you who don't know how to read those scientific graphs, if you're ever gonna see the paper, so each bar graph here is a single patient. So we all start at the time zero right here, the straight line, and depending what happens to your cancer, so if your cancer shrinks, the bar graph goes down. If the cancer grows, the bar graph goes up, and that what you can see here is a visual representation of each individual patient who was enrolled in the study. As you can see here, the chance of the patient responding to sotorasib is about 37%, which is good in our opinion in lung cancer setting. Duration of response is about 11 months. We also see, if you look at all the patients who responded or did not respond, it takes about 6 months before the cancer starts progressing. and look at adagrasib. Again, the drug is not yet FDA approved, but also looks pretty good. The response rate is approximately 45%. We do not yet have any knowledge of the duration of response or median progression-free survival because adagrasib came to studies a little bit later, so we just have not had enough chance yet to follow those patients long enough to understand what is the duration of response on adagrasib. Both of the drugs have side effects. The side effects are actually pretty similar. You can see here about 31% of the patients on sotorasib will have diarrhea, about 19% will have nausea. We also have to watch for the liver function tests, and you can see here ALT and AST increased. Fatigue happens in about 11% of the patients. And if you look at the adagrasib data, very similar. So about 54% will have nausea, 51% will have diarrhea, vomiting has been described, fatigue, similar incidence of elevated liver enzymes. Some adagrasib has been shown to have prolongation of your conductivity on your heart, but otherwise the drug seems to be okay tolerated. So as I mentioned before, even though response rate is 37 to 45%, this is not as high as we see in patients with EGFR mutations and ALK mutations, where our response rates are much higher, like 60 to 70%. And the duration of response here of 11 months is also not as good. It's better than chemo, but it's not as good as the duration of response with other oncogenically driven cancer where we have orally available targeted therapy. And that's why, that's because KRAS is pretty smart and it can easily adapt to targeting KRAS by shifting the balance back into the active state or trying to utilize other pathways to stimulate or to activate the KRAS. And therefore, we think that the future is behind combinations. So we have to be in the future combining the KRAS drugs with some other medications. And here on the right side of the slide, you can see all the combinations that are currently being looked at in patients with KRAS G12C mutation. We are also now trying to understand why patients develop resistance. For example, patients who initially responded to KRAS and then they stopped responding. We want to understand why, because only by understanding why we can approach it, we can target it. And what we learned is sometimes tumor changes the site where the drug binds. So if the site is changed, the binding site is changed in the shape, the drug cannot get to the binding site. Also, the tumor can start making a lot of KRAS. So before, if you have, let's say, just to explain it, if you have 2 KRAS molecules and 2 drug molecules, then 2 equals 2, the KRAS gets blocked. But what happens, cancer can now make 10 KRAS molecules, and I still have 2 molecules of the drug, so there's not enough drug to inhibit all the KRAS. And also cancer can make what we call a bypass pathway. So if I'm blocking the KRAS pathway, cancer can make a go-around road and then try to still signal or give the call to the center of the cells to divide utilizing pathway other than KRAS. And we also saw that the patients can develop other mutations. For example, patients can develop mutations in ALK, which they did not have at the time of the starting KRAS drug. And that's how the cancer tries to evade us. That's how the cancer tries to fight us when we are giving successful drugs. So those 2 drugs that I mentioned are not the only one that's being looked at. There is 3 other compounds from Eli Lilly, Janssen Pharmaceutical, and Genentech, which are very early in development at this point. We do not have any data on clinical activity of the medication. I don't know if we have any colorectal cancer patients listening to us. The colorectal cancer patients, for some reason, are a little bit more difficult to inhibit KRAS. We see no activity of sotorasib in colorectal cancer patients with KRAS G12C mutation, but we do see some activity with adagrasib, which showed that response rate to adagrasib in KRAS mutations is about 17%, which is less than what we see in lung cancer patients, but still probably better than single-agent chemotherapy in this setting. And so in summary, KRAS G12C mutation is now targetable. Sotorasib is FDA approved. Adagrasib is being investigated. We see responses with both drugs at around high 30s, low 40%. Unfortunately, as I mentioned, responses are not as frequent or durable as with other targeted therapy. And we are looking at combination therapy, and we already know what resistance patterns appear in those patients. So I hope that eventually we will be able to target that resistance. So it's very important to make sure that your cancer is being tested for the KRAS G12C. If you had what we call the next generation sequencing, where we test about 400, 500 genes, then I'm pretty sure that KRAS was tested in your tumor. But if your oncologist is doing what we call the single gene testing, where they're just testing each gene by itself, then we want to make sure that the KRAS G12C is tested. One thing I also wanted to mention, which I forgot when I was talking, so the KRAS G12C inhibitors will only work for patients with KRAS G12C mutation because they attach close to C. If you have a KRAS G12D mutation, which I mentioned is more common in non-smokers, so KRAS G12A or KRAS G12V, unfortunately, those drugs are not going to work because you're missing the place for the drug to attach. There are drugs in development for KRAS G12D, V, and A, but those have not yet have any clinical data. They just either starting clinical trials on those drugs. So at this point, it's too early to report on the efficacy of those medications. And that will conclude my talk. And thank you very much for listening.